Anemia is very common. It affects about 1 in 3 people attending a hospital either for medical or surgical reasons. In the setting of a surgical patient, 1/3 of people have preoperative anemia, and that is associated in large database analyses with a worse outcome in terms of patient complications, length of ICU stay, length of hospital stay, and actual mortality as well. Therefore, anemia is a risk factor that predicts outcome, but it's associative and not causal. There's been no proof that correcting anemia, whether by blood transfusion or other means, actually changes that risk, and this is the setting of an ongoing clinical trial called PREVENT. Iron deficiency is the most common cause of anemia worldwide. The primary causality is dietary, so poor iron intake. The secondary being women's health or blood loss, and this effectively is emptying the iron from the other end. Other causes, B12, folate, and then moving on to renal and thalassemias, etc., form the minority. Therefore, it's wise to assume that most preoperative anemia is related to iron deficiency. In this setting, we know that intravenous iron is more efficacious to correct anemia and increase hemoglobin compared to oral iron. I've been quite specific in what I said there. The Cochrane review shows that intravenous iron can increase hemoglobin or correct anemia in a better manner than oral iron. And so that is efficacy. That is the intravenous iron doing what it says it's going to do. The effect, i.e. patient benefit, has not been proven in that setting. So in the preoperative setting, NICE guidance states that you should identify and manage preoperative anemia. The low level of evidence and the low level of recommendation was the use of intravenous iron can be used where oral iron is not tolerated or does not work. The next question is, what do you mean by that? So, not being tolerated is quite common. Oral iron is associated with GI side effects, constipation, abdominal pain and diarrhea. And the many problems are associated with the dosing. So this is a dose effect. If you give 200 milligrams of an iron salt 3 times a day, you'll get 3 times more likely complications than if you give it once a day. So if someone's got complications, stop, give them a week's rest, and then start on 1 tablet of iron alternate days. It's probably just as good. Failure is when the hemoglobin has not risen by 10 grams per litre over a 1-month period. And in that situation, that is an indication for intravenous iron. That's a really good question. We know that we discharge virtually all surgical patients from hospital with anemia. The causality is mixed. It's blood loss from the surgery, blood loss from junior doctors taking too many bloods out of the patient, and then finally the inflammatory response following surgery. In this setting, there are 7 randomized controlled trials on the use of oral iron, showing no benefit whatsoever. Because in the setting of an inflammatory state, the inflammation upsets the normal iron metabolism pathway. What happens is that the iron transport protein ferroportin that moves iron out of cells is downregulated due to hepcidin, and hepcidin's upregulated in inflammation. So if you have an operation, your inflammation lasts for about 4 to 6 weeks, hepcidin's cranked up, ferroportin shut off. So when you measure the blood iron levels, you're measuring ferritin, which is the iron stored inside the white cells on the macrophages. Therefore it's really high, because the iron can't get out of the cells because it can't be transported. So the bone marrow is functionally starved of iron, and this is what we used to call anemia chronic disease, but is in fact a functional iron deficiency. Does intravenous iron work in this setting? Yes, it does. If you give intravenous iron on intensive care as per the Ironman trial, it results in a rise in your hemoglobin. The fundamental management of anemia is to address the underlying problem, and when looking at blood transfusion, the standard mechanism for anemia management, This can be addressed through a program called patient blood management. Patient blood management is divided into 3 areas. Identifying and managing the anemia, so if you do have B12 folate or iron deficiency, correct the underlying cause. Control and prevent bleeding. We commonly over-anticoagulate people in the bridging pathway to surgery. The BRIDGE trial, published in New England Journal of Medicine 2 years ago, clearly says that there is no role for bridging low-risk patients. And in fact, this just increases blood loss at the time of surgery. In the UK NHS-BT audit, of patients on warfarin, only the minority had their warfarin stopped 5 days prior to surgery. So, stopping anticoagulation is vital. The use of antiplatelets in the perioperative period is totally up for debate. The Atticus trial showed no benefit of the use of aspirin in patients undergoing cardiothoracic surgery. The other area is the use of tranexamic acid. I can't think of a reason outside of neurosurgery why you should not use tranexamic acid at the time of operation. 1 gram at induction. Tranexamic acid does not cause clots. It stops plasmin binding to TPA to break clots down. So it doesn't cause clots, it prevents ongoing ooze, and particularly when you look at the clinical trials, of which there are hundreds, then it reduces the need for drains after surgery because it reduces the post-operative ooze and blood loss. And finally, restrictive transfusion practice. In the hospital, we stock blood in a unit. We don't stock it in 2 units, we stock it in 1. So stop prescribing 2 units. If it was supposed to be 2 units, we would just simply put more blood into 1 bag. So give a unit of blood, increase the hemoglobin above 80 or above 70 in someone without cardiac risk, stop and recheck the need. Bear in mind that a blood transfusion is associated with risk, and 1 in 160 blood transfusions is stopped in the hospital setting due to perceived risk to the patient. That's quite a lot. So use blood cautiously and carefully. It's very interesting, and I think the use of clinical trials is absolutely fundamental to advance our thinking and our understanding. The PREVENT clinical trial is randomizing people to intravenous iron or placebo 2 weeks prior to surgery. This is abdominal surgery. The ITAX trials, randomizes people prior to cardiac surgery. The question I'm asking is whether or not correcting anemia by the use of intravenous iron improves patient outcomes. If you swap a unit of iron for a unit of blood, why make life difficult for yourself? It's difficult bringing people into hospital prior to surgery, but it's quite easy giving a bag of blood during the course of an operation. And if there's no real difference to the patient, then always pick the easier option. Where the change I've seen come is actually not in this setting. It's raising the awareness that there's a treatment option where oral iron has failed, and raising the awareness of iron deficiency. So in that regard, iron deficiency is a disease, anemia is just a consequence, because your iron stores deplete and you become iron deficient long before anemia develops, and the symptoms are related to iron deficiency. We can see this clearly in women's health. Every other person in the world is a woman. Everyone's got a mother. 1 in 10 women at any point in time suffer with iron deficiency anemia, 1 in 3 in their lifetime. And the symptoms are diverse, from fatigue and tiredness to brain fog, muscle aches, and 12% of women postpartum will develop some form of depression, and this is preventable with appropriate treatment of iron deficiency. So where do I think it's made the greatest impact? Actually, ironically, not in the surgical setting, but actually more in a population setting.